Hi and welcome to Dental XP. My name is Miguel Stanley, and today I'll be presenting a fun case that my team finished quite recently. This case isn't going to be so much about the technical prowess of the micromanagement of each detail, which I personally think we were quite lucky with and quite fortunate with, but more the treatment planning. A great man, Abraham Lincoln, once said that if you're given 12 hours to chop down a tree, spend the first 11 sharpening your axe. And more, I believe that it's in the treatment planning that you win these big cases. And over the years, a lot of people have asked me, what is the defining factor for you to have success with your cases? And it really is with the treatment planning. And I find that a lot of junior dentists and smaller clinics that don't feel that they have the support from a large team, they seem to lose themselves in the micromanagement. And, these cases go out by saying, what does the patient want? What are the problems? Where are you right now? And what does the patient require? And what do you need to get there? And actually, it can become a lot of fun. Here we have a 32-year-old woman. She's obviously lived in many countries around the world. She doesn't have any medical problems, and she doesn't like to use her removable denture. She wants to actually get rid of her partial denture. She has a slight facial asymmetry in the extra oral examination. And here we can see a close-up photograph. Now, when I look at these photographs like this, and you can see, she's missing the central incisor. And as an implant dentist, the first thing that we want to do is go in and place that implant, and we can do some local regeneration, what have you, and actually think that, job well done. But it's these little things, these little micro gaps, these little diastemas that we have that the patient can get upset with. And it's the actual measuring of the interdental spaces to make sure we're doing things correctly. Because what we don't want is this patient to look in the mirror after a lot of work to get that tooth in place and say, you know what, I'm not happy with my smile. So we have to step back and, like I say, not look at the trees, but look at the forest and step back and say, well, what else has this patient got going on? So here we've got the intraoral photographs, and we can see she's missing quite a few teeth on the top. She's had some dental work done on the top and the bottom, and this is quite a classic case all around the world that our patients present, and they are using partial removable dentures to replace the teeth that they're missing, and with wear and tear. And of course, now with all the information and the internet, a lot of people are more open to having dental implants. I remember, 10 years ago, 12 years ago when I started, to sell a dental implant, to convince a patient to place dental implants was quite a hassle. Nowadays, that's not the case, thankfully. So we have a patient who has obvious aesthetic requirements, wants to get rid of her partial denture, but she can't just rush in and do what she wants. She actually has to do a few more things before that. So if we look at the panoramic X-ray, we can see that she has some root canals that have been done, some here that aren't in very good shape. She's missing 1, 2, 3, 4, 5, 6. She's missing several teeth. Her occlusal plane is not all in the place. So let's start from the basics and not just talk about the simple stuff. Let's see what can we do to put this mouth in an absolute perfect condition. So we have to take a closer look. Look at each tooth individually. And here we can see, yes, this root canal is not correct. This one might be okay. We get our endo team in here to have a look at this. And the way we work is that we sit down with the whole team and everybody gives their opinion about their specific area and what they would do to bring this smile to perfection. So, we'll take it even a step further. Let's look at a 3D imaging of what we have here. Let's look at how thick that bone is. Now, we know that her major concern is that central incisor. Do we have enough bone? Yes, we do have enough bone. But there might be, requirements for some minor grafting here. So it's very, very important to have as much information as possible before you go in and do these complex treatment plans. So She has a good oral hygiene. She's missing 1, 2, 3, 4, 5, 6 teeth. She has a diastema. So if she did have all her natural teeth in perfect function, she still would have spacing in between her teeth, and then probably would be a patient for veneers or just orthodontics. But we have to imagine, that there is going to be a large diastema there, because even if we do replace that tooth with the mesial distal measurement in the right place, she will have a space. And a lot of people forget to measure that before they place that implant, and then they replace it with an oversized tooth, and then they have very unsatisfied patients. She has some mesial angulation of some teeth. She has incomplete endodontic treatments. She has a reduced buccolingual thickness of the bone. So when we place an implant, we need to select the correct implant for this thickness. She has a thin gingival biotype, a high smile line. So we really cannot afford to make any mistakes with our treatment planning here, because whatever we do wrong, if there's any metal showing, it's going to come out, because she doesn't hide that behind her lip. She has some old composite fillings. She has a reconstruction of some other fillings. She has some lead amalgam fillings and a crown in her mouth. So she's no stranger to dental treatment. But this is a patient who's obviously done tooth by tooth. She hasn't ever sat down and had a complete plan to say, well, this is what we're going to do in phase 1, phase 2, phase 3, phase 4 to get your mouth to that dream state that you want it to be in. And if you're just going to look at and micromanage each tooth, you're never really going to get that. So we decided this is the perfect treatment plan, from oral hygiene, orthodontics, to get those diastemas, to get the teeth into the correct positioning, correct the rotation of those teeth, straighten those molars so we can get those implants in the right place. Let's take out the wisdom teeth so we can actually afford a little bit more space to upright those molars, retreat those endodontic treatments that aren't correct. Do some post build-ups, core build-ups on those root canal teeth. On the lower left quadrant, we might want to actually have our lab rebuild that, because it's quite a larger reconstruction. Redo those fillings, place implants in the missing areas, simultaneously plan for bone augmentation at the same time of doing that implant placement. We need to do an abutment customized over that central implant, because we know that we need higher aesthetics, and just do straight metal ceramic crowns fused to the to metal on those implants in the posterior regions, and do some bleaching so we can offer her a perfect smile. Now, that is everything in a nutshell. And of course, when you want to communicate this to this patient, you want to show that there are other options. And for those of you that are seeing this lecture, just pause here and have a look at the alternatives that we had. We had some without orthodontic treatment and some without orthodontic treatment and implants, always offering patients a cheaper alternative. We cannot forget that we live in a recession, and that patients are going to want cheaper solutions. However, the better you are at communicating and the more experience you have at doing this, and in our team, we're fortunate to have an endodontist, a cosmetic dentist, oral hygienists, we have implant surgeons, we have prosthodontists. We work with our lab, every day. We have a lab that works practically just for us. So we have everything in-house that allows us to manage these cases. If you don't have this kind of option, then make sure you have colleagues in the neighborhood that can, because you need to have all these tools when you want to do this. So she felt confident with that explanation, and she went ahead and decided to choose the right and correct, more complex treatment plan. So we break this up into 2 phases. Phase 1, which is we call the health treatments, which is everything before we place on the orthodontics. Unfortunately, I still see so many people, so many clinics putting on orthodontics with gingival problems, with perio problems, with tooth decay. It's unacceptable in the 21st century that clinics are still doing this. I always say, don't make a buck, make a difference. And that will set you apart from your colleagues. That is one of the major keys to success. You have to be ethical in this profession. So we send, over a period of time, this patient to one part of the team, Dr. Carlos and Dr. Inez, that take care of and of course our oral hygiene team that take care of all the phase 1. And once she's done, she will then go into orthodontic treatment and the implant treatment. Now, one of the cool things about this is that we do everything simultaneously, saving the patient visits. Now, a lot of you might have patients that come from abroad or from overseas, and it's very important to do correct planning of these cases. So on a third phase, then we'll place the implant. Now, what we do here is we actually place the implant before we remove the orthodontics. Why is that so important? So it allows for the correct healing time for the implant, but it also the finalization of the orthodontic treatment. So why have a patient go through 12 months or 16 months of orthodontic treatment, then remove the orthodontics, the braces, and only then place the implant and wait then another 2-3 months? It doesn't make sense to us. So what we do is we do everything simultaneously. So she will pop into the orthodontist, we'll take off the braces, place the implant, then she'll put the braces back on, and of course, we'll only place the implant when the bone is at the correct positioning and when the orthodontist says, that she feels comfortable to let us do this. And of course, in the last stage will be the cosmetic oral rehabilitation side of, the bridge and crown work over the implants once they are all integrated. So in this case, after the health treatment, we started the orthodontic treatment. Here we just got the classic orthodontic treatment. We use several systems. We use Invisalign, we use Damon, and in this case, this was the selection that our orthodontist decided to use. Faster results, and here we have she placed the top in April and the lower one in February, and we removed that in September 2012. And as you can notice, we had a little bit of composite placed here, because this, of course, was a temporary crown that we had here, glued, fused to the adjacent teeth. So just for aesthetic reasons here. And during the orthodontic treatment, we placed an implant. In this case, we placed a 4.2 13 millimeter MIS7 implant. So the patient came in on the day, had the wire removed, under local anesthetic, raised a little flap, placed the implant. Now you can see we've got some thinning here of the buccal plate, as we knew previously due to the 3D image that we had. So we decided to do some augmentation here with Bond Bone. Bond Bone, as you know, is bicalcium sulfate. It is a product from MIS. It's a wonderful product that we've been using. You can mix this with a bone graft. In this case, I believe we mixed it with some BioOs, just to give a bit of scaffolding here, but you can use it as a standalone product, just to help create a bit of volume here. And we can see the X-ray post-op. This is the immediate post-op X-ray. Simultaneously, implants were placed in the posterior region, and I can actually go back there to say that this implant was placed last. We had some of the autogenous bone that was used while placing these implants to mix with the Bond Bone, because it can be done simultaneously. And you can already see here, that these teeth have had the root canal and post and cores done. And after a few months, we have the final photographs with the final restorations done. And it's like I said, I just wanted to show you the treatment planning, not so much the surgical or prosthodontical treatment here. There's so much of that on Dental XP. But as you can see, we have single crown, single crown, single crown, natural tooth, single crown over implant and zirconium abutment, a single crown. Why did we choose to do the other crown at the well? Because basically we find that by doing the two centrals, we create a little bit of more harmony here. So when we go back here, we've got the laterals are natural, the canines are natural, and here we have a 3-element bridge of ceramic fused to metal, screw retained. Here you can see the orifices, this screw retained for retrievability, and that is the final aspect here. You can see how the soft tissue is quite nice around this implant. And remember, she has a high smile line, so it's super important to get that done. But because she did the orthodontic treatment prior to placing these, to doing this treatment, we managed to close all the gaps and get a more harmonious and more natural looking smile. And of course, we've also done some bleaching here to make sure that we get the right color. And here's the final panoramic x-ray. So we have the 1, 2, 3, 4, 5, 6 dental implants placed, all with ceramic fused to metal crowns, screw retained or cemented. Here we have a zirconium abutment. You can see the good work of the endodontic team here and the crown. Look how the occlusal plane is all in place, and she's got all those teeth in function. And here we can have the final 3D scan. We can see the implant is fully in the bone. You can see the buccal plate there. We believe that the bond bone really did help slow down the resorption there and keep everything in place. And here we have the final x-rays. You can see the beautiful adaptation of that crown. And we've been having really good results with these implants. So before and after, before and after, before and after. Now, one thing that's really important is that if we had just chosen to do the front teeth, she would have come in for just the same amount of appointments. So when you communicate to your patients, make sure that they understand that they can get more work done in the exact same time frame. And once they understand that, well, if I'm going to come in, I might as well just do everything. And it's just logic. And once again, here, our philosophy at the clinic is full mouth rehabilitation. You can't have anterior aesthetics if you don't have posterior function. This is something that's just a basic rule in our day-to-day practices. So that's pretty much it. I just wanted to present you this case of treatment planning, and look forward to the next one. Thank you.